Good morning, everyone. I welcome you to the lecture series started by UN Mehta Institute of Cardiology and Research Center. Today, we'll be starting the lecture series on cardiac embryology. And we have an absolute treat for all of you today. I have the distinct pleasure and honor of introducing Dr. Tushar Gajjar sir. I think each and every cardiac surgeon in India knows the name. Every trainee during his residency reads the book which we call Satya Sai Notes, which is compiled by Dr. Tushar Gajjar sir. Sir is a great mentor, a fantastic teacher, and an exemplary surgeon. He is one of those few people you will meet who is adept at doing the entire spectrum of cardiac surgery, be it CABG, adult valvular cases, pediatric, and complex congenital cases. Sir has more than 2 decades of experience after his training, during which he has more than 50 publications to his name. He has organized multiple international and national conferences and also has had the distinct honor of being the associate editor of IJT-CVS. Without further ado, I would like to welcome Sir to make cardiac embryology look easy, and we all better be paying attention because this is going to form the basis of understanding the entire spectrum of cardiac surgery. Welcome, sir.
Hello, myself Dr. Tushar Gajjar, Senior Pediatric Cardiac Surgeon, UN Mehta Institute of Cardiology and Research Center, Ahmedabad. Today, we are going to learn about cardiac embryology. This embryology made so easy that you can understand in much better way how the heart develops in a child. Today, we are going to see about the normal development. We are going to learn about the normal development of heart under these headings. Let us start with the basics. In human, at the third or fourth week of development, the heart starts forming. Initially, there are two endothelial tubes which fuses in the upper part and remains separated in the lower part. So, the fused upper part or the cephalad part and the free caudal part. Slowly and progressively, this tube develops some dilatations and some constrictions. So, after formation of this dilatation and constriction, if we see from below up, the lowermost portion is called sinus venosus. The dilatation above is called primitive atrium. Above that, primitive ventricle. Above that, bulbus, and the topmost part is called truncus. The constrictions between are called sino-atrial junction, atrioventricular canal, ventriculobulbar foramen or bulboventricular foramen, and bulbotruncal junction. This we are seeing in a lateral view. The tube is seen like this from the frontal view. So it has, sinus venosus has two horns. So this endothelial tube is covered by myocardial epicardial mantle in the embryonic mesoderm, which in future forms the myocardium, epicardium, and pericardium. So let us see the fate of heart tube. The heart tube goes into the looping. This is the first step which leads to the formation of heart. So we have seen the heart tube is in a straight line. It is not having even the shape of heart, but this one movement will make the heart little something like like a heart. So what is bulboventricular looping? Here the bulbar component of the heart tube moves in front and to the right of the primitive ventricle. This is called a de-looping. I'll repeat again. The bulbous portion of the heart tube moves in front and to the right of the primitive ventricle. So it forms 180-degree looping. This is called de-looping. A bit confusing in this picture. But if we see this picture of the heart tube, where the bulbar component of the heart tube has come in front and to the right of primitive ventricle. Why this happens? It happens because of either restrictive influence of pericardium or the most acceptable theory, it is differential cell growth. So with the bulboventricular looping, the straight heart tube has developed some kind of shape which is looking like an heart. It is having two curvatures, the inner curvature and the outer curvature. Remember this inner curvature, which is very important during the future development of the various parts. With this looping, the atrioventricular canal and the bulbotruncal junction came in the same line, and the bulboventricular foramen became perpendicular to the above two. This heart tube also contains some endocardial cushions throughout its length, but these endocardial cushions remain as it is at two places, that is atrioventricular canal and bulbotruncal junction. Rest of the places, this endocardial cushion disappears. So let us see the development of atrium. So atria develops in three parts. Development of atria from sinus venosus and privative atrium. Development of systemic as well as pulmonary venous system. And finally the atrial septation. So the atria develops from sinus venosus and privative atrium. The sinus venosus, what we saw, has two horns. We have seen these two horns. Each horn is having three tributaries. So it is cardinal vein, umbilical vein and vitelline vein. That is there on either side. We will see further development of both horns. So initially both horns are of equal size. So you can see left and right sinus horn in the heart tube. Slowly and progressively the left horn starts regressing. So the right horn becomes prominent and comes in the center. So let us see the normal systemic venous development. Now there are two types of veins. One is visceral vein, which drains viscera, and somatic veins, which drains the body, the wall. The visceral veins are right and left vitelline veins, which drains from yolk sac, and the right and left umbilical vein, which drains from placenta. The somatic veins are the cardinal veins. Now cardinal veins are having anterior and the posterior part or the caudal part. So right anterior, right posterior, left anterior, left posterior. So if you see in this picture, the right umbilical vein distal part disappears. The right vitelline vein distal part disappears. Part of it remains patent. Left vitelline vein disappears. left umbilical vein disappears proximally, and ultimately what we see is the left umbilical vein continuing as the AVC through ductus venosus, which we'll see will form in the liver. So in the livers, if you see, there are sinusoids, and these liver sinusoids will form ductus venosus from the left umbilical vein and part of left vitelline vein. Let us see the somatic veins fate. So we have right and left anterior cardinal veins, posterior cardinal veins, and what you see here is a common cardinal vein. So a communication develops between right and left anterior cardinal vein. The left cardinal vein disappears or regresses and forms a ligament. The right common cardinal vein and part of anterior cardinal vein will form the superior vena cava. The communication will form the innominate vein, and the left anterior one will form the left internavicular vein. So ultimately, if you have seen that posterior cardinal vein of the right side will form the azygous system. So cardinal vein will form the superior vena cava. The left horn, which has regressed, will form the coronary sinus, and the ligament will form the ligament of Marshall. The inferior vena cava develops from various parts. Both posterior cardinal veins are there, right and left posterior cardinal vein. They develop communication like anterior cardinal vein. They develop communication between them. There is a supracardinal vein and subcardinal vein which develops along with the posterior cardinal vein. They have communication in between. Slowly and progressively, these cardinal veins, subcardinal and supracardinal vein, portion remains and remaining thing disappears. This subcardinal veins, they join with the hepatic sinusoids where it forms ultimately the inferior vena cava. So if we see from below up, these are the posterior cardinal vein communication. This is the posterior cardinal vein. The red one is supracardinal vein. The green one is subcardinal vein, and this is a junction between them. The yellow one is hepatocardiac veins, which we formed in the liver from vitelline vein and umbilical vein. And this hepatocardiac channel gets communicated with the right atrium or sinus venosus. Now, along with posterior cardinal vein, two more venous tributaries develops. They have communication in between. They drain the body wall. So the posterior cardinal vein, and they are communicated with the both side posterior cardinal vein. This communication, when it develops, the posterior part of posterior cardinal vein will disappear on either side, and this system will form the azygos on the right side, and on the left side it forms the hemiazygous system. So let us see development of pulmonary venous system. So pulmonary venous system develops from the splanchnic plexus in the lung buds. From lung buds, the splanchnic plexus develops, which grows at the same time from posterior wall of the primitive atrium, a outpouching develops. This outpouching will go and communicate with the splanchnic venous plexus. Slowly, this splanchnic venous plexus and this primary pulmonary vein will come down and fuses into the primitive atrium. So we can see here in this picture the outpouching splanchnic venous plexus, which is having a communication with left common cardinal vein, right common cardinal vein, and umbilical vein. So this primary pulmonary vein joins with the splanchnic plexus. Slowly that forms a single chamber and then gets absorbed inside the primitive atrium, and they move apart and they form a pulmonary veins. So this is how it gets incorporated inside the primitive atrium. Slowly it gets separated out and it forms right and left pulmonary veins. Let us see the part of atrial septation. Initially, the atrioventricular canal is in round shape. Later on, it becomes oval. As I said earlier, the endocardial cushions remain patent at atrioventricular canal and bulbotruncal junction. So, in atrioventricular canal, the endocardial cushions are dorsal and ventral, or anterior and posterior. These endocardial cushions, they grow towards each other and divide the atrioventricular canal into two parts, right and left. So once the endocardial cushions has divided the atrioventricular canal into the right and left part, a septum grows from the roof of primitive atrium, which grows towards the endocardial cushion. It grows, but it doesn't fuse with the endocardial cushion. A foramen remains there, that is called foramen primum. Due to cell lysis into this septum, this is called septum primum, and when the lysis occurs in these cells, the septum moves downward and fuses with the endocardial cushion. This foramen is called foramen secundum. Another infolding occurs from the roof of primitive atrium in this picture if you see, and that infolding grows downward. It is slightly away from the previous septum. It doesn't fuse with it and makes a wall kind of thing, or a hanging roof on the septum primum. This portion forms the limbus of fossa ovalis, that is called septum secundum. Now we will see about the development of ventricles. Ventricles develop under various headings. We will make it very simple. It is a bit a confusing subject, but with pictures you will be able to understand clearly. So let us see. So we have seen this is the normal heart tube after bulboventricular looping. The bulbus has come in front and to the right of primitive ventricle. This is called de-looping. This also we have seen the AV canal, the atrioventricular canal gets divided by the endocardial cushion and the atrial septation occurs and it divides the atria into two parts. We are interested in this part where the endocardial cushion divides the atrioventricular canal into two parts, right and left. So the second step is that tube has developed a shape of somewhat like heart from bulbus in the primitive ventricle to trabecular outpouching develops. This trabecular outpouching will form a septum in between, that is called a trabecular septum, and the bulboventricular foramen is on the top. Now, as we have seen, the atria is divided into right and left. AV canal is divided into right and left. The primitive ventricle is going to form future left ventricle. The bulbus is going to form future right ventricle. So, blood is still flowing from this direction into the outflow, means it's unidirectional. Now, when bulbus is going to form right ventricle, this portion of the primitive ventricle has to move towards the right side. This sleeve has to move towards the right side. So, the moment the sleeve moves towards the right side, the right AV canal will come in contact with the distal bulbus. The left orifice, AV orifice, will come in communication with the primitive ventricle. Still, there is a bulboventricular foramen. The blood has to go from primitive left atrium or left atrium through left AV valve into the primitive ventricle, through bulboventricular foramen into the bulbus, and then outwards. So if we see, still the blood has to flow in this direction only. The right atrial AV canal orifice has moved towards the right side, but behind. So movement of right, that sleeve beneath the right AV orifice towards the bulbus, is called rightward shift. This is called a rightward shift. Now we would like to see about the distal part of the bulbus. So as mentioned earlier, the endocardial cushion is there into the bulbotruncal region as well. Here the endocardial cushions are of lateral variety, means they are lateral cushions. They divide the bulbotruncal junction into anterior and the posterior canal. Like AV canal was divided into right and left by the anterior and posterior cushions, here the cushions divides the bulbotruncal junction into anterior and posterior one. See here, this is called the inner curvature, still there. This is a cut section, difficult to understand here, but some more pictures will help you to understand what is this inner curvature of heart. So now the left atrium has communicated with the left ventricle, the right atrium has communicated with the right ventricle, but the outflow is still into the bulbus, means right ventricle. So now aorta and pulmonary artery, future aorta and pulmonary artery, has to get its own outlet, means its own chamber. For that, this inner curvature, which I said earlier, has to regress. If it regresses, then the posterior orifice of the bulbotruncal junction will come in communication with the left ventricle. Difficult to understand from this picture. If you see this picture, this is left atrium, left AV orifice. The blood has to come and go through this bulboventricular foramen into the posterior or outflow tract, while the right atrium has come behind and it is in communication with right ventricle, it is directly going into the outflow tract. So this inner curvature has to regress. Let us see in some more picture. See here, earlier we saw this inner curvature has regressed, but it will be easy to understand through this picture. Here is the trabecular septum, here is the bulboventricular foramen, here is the inner curvature of heart, here is the right ventricle. So still both outflow tracts are from the right ventricle. This inner curvature has to regress. The moment inner curvature regresses, the aortic valve and mitral valve will come together like this, and the left ventricular cavity through bulboventricular foramen will be in communication with the posterior outflow tract, that is aorta. So with this regression, this primary interventricular foramen or the bulboventricular foramen will form the outflow tract. At the same time, another opening develops, that is called secondary interventricular foramen. I hope you have understood by this. So with this, the aortomitral continuity has formed. Left ventricle came in communication with the posterior outflow tract, that is going to form future aorta, and a new foramen formed, that is called foramen secundum. So we have seen at the atrial level there is a rightward shift, and at the outflow tract level it is leftward shift of the septum. So this secondary interventricular foramen will slowly be closed by fibrous tissue in this place. So we'll see the ventricular septum on RV side is having inflow, trabecular portion and outflow. The inflow portion got from the primitive ventricle raised to where the part of right ventricle. If you see on the left ventricular side, there is a trabecular septum, outflow septum and inflow septum, that is from primitive ventricle. The trabecular septum will form the thick muscular septum in between, which is going to form, this is a Y-shaped structure that is going to form the trabecular septum marginalis. The infundibular septum is going to come and fuse with this. Part of it will be forming the fibrous tissue, that is going to form a membranous septum. This infundibular septum will come and fuse with the between the anterior and posterior limb of trabecular septum marginalis. So if we see that ventricular septum is not straight, it's not in same line atria and ventricular septum. There is a endocardial cushion in between, a tissue in between. Slowly with the development, the tricuspid valve will go towards the apex, the mitral valve will be on the higher side, and this endocardial cushion will form the part of membranous as well as AV septum, atrioventricular septum. Let us see the development of outflow tract. Outflow tract starts developing from under these headings. So first, the semilunar valve will form from endocardial cushions at the bulbotruncal junction. These endocardial cushions are two lateral cushions and two anteroposterior cushions. So that forms, these four endocardial cushions will form the semilunar valve, and the rotation will form the final structure of the semilunar valve. If you see this picture, the bulbous cordis or the bulbous part elongates, and this part can be divided into three parts. The proximal bulbar cordis, the middle or the conus portion, and the distal, that is called truncus arteriosus. So we have proximal, the bulbous portion that is going to form the right ventricle. This middle portion, conus cordis, is going to form the conus and the infundibular septum from there, and the semilunar valve itself, and the distal portion is going to form the truncus arteriosus. As we saw earlier, the bulbotruncal junction by two lateral cushions gets divided into anterior and posterior part. So there are four truncal and two coronal cushions they develop. They are dextro-sinistro cushions of both conus and truncus, and they fuse to form conotruncus septum. These interlaced cushions, they play a role in formation of semilunar valve. So as we saw earlier, there are four cushions. They are interlaced and they will form the semilunar valve. So outflow tract partitions in a spiral fashion. Because of their cushion, they are positioned in such a way that they grow in such a way and they form a spiral kind of septum, which leads to the final development of the or separation of the outflow tract. So initially, if we see the septum, if it grows straight down, the aorta will be in connection with the RV and PA will be in connection with the LV. So here there are two rotations occurs into the conotruncal area. The first conoventricular junction means conus and the proximal portion of the bulbous cord is what we saw. The proximal portion of bulbous cordis, which is also called a conoventricular junction, and the other at the middle and the distal portion of the bulbous cordis, what we saw earlier. That is called conotruncal junction. So we have bulbotruncal junction, bulboventricular junction or conoventricular junction, and conotruncal junction. These rotations will occur in a counterclockwise direction and at 110 degree. So conoventricular rotation brings the aorta in continuity with the LV and PA in continuity with the RV. Conotruncal rotation brings the normal position of aorta in relation to the pulmonary artery, what we saw during the semilunar valve development. That means it will be aorta will be the PA will be left and anterior, and aorta will be right and posterior. The second most important thing happens in conotruncal development is the absorption of conus. Initially, there are two conuses beneath each outflow tract. If you see here, there are two conuses. Conus is nothing but a part of bulbotruncal junction, a bulbo-conoventricular junction. This conus, they are present beneath both the outflow tract. Whichever conus disappears, that artery will remain behind, and where the conus is present, that artery will be pushed forward. That's how the pulmonary artery is pushed forward and the aorta subaortic conus disappears, which remains behind. That's how the pulmonary artery is anterior to the aorta. Rotation brings the pulmonary artery to the left of the aorta. We have seen this transfer of outflow tract by regression of the inner curvature of heart and the subaortic conus. The subpulmonary conus remains, and that's how the pulmonary artery is pushed anteriorly. With this regression of the inner curvature, the aortomitral continuity will develop. LV outflow tract will be formed by the bulboventricular foramen, and a new secondary foramen develops, that is called secondary interventricular foramen, which will be closed by a fibrous tissue. This secondary interventricular foramen will be later on fused or closed by the fibrous tissue. So here we are seeing these are the truncal cushions, these are the conal cushions. They rotate in a spiral fashion. Finally, this cushions, they form a infundibular septum or the conal septum that fuses with the trabecular septum. The trabecular septum marginalis, Y of trabecular septum marginalis, and it will form the interventricular septum. The fibrous tissue and part of AV canal will form the membranous septum. The trabecular septum will form the muscular septum. So this was the normal development of heart. Next session we will see the cardiac embryology and its anomaly.